Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 564 of our pharmacotherapy series, which majors in sleep disorders. It has been a month since his return and PCB continues to have difficulty falling asleep. So my next question to you reads, what alternative medications, aside from triazolam and ramelteon, offer rapid onset, have low risk of daytime sedation, and can be administered safely for weeks to months if necessary? Considering their rapid onset of action, non-benzodiazepine hypnotic medications, such as zaleplon, zolpidem, and essoplon, are all potential alternatives for PCB. They have varying degrees of selectivity for the alpha-1 subunit on the GABA-A receptor. This selectivity imparts hypnotic efficacy with no significant anxiolytic, muscle relaxant, or anticonvulsant effects. Consequently, non-benzodiazepine hypnotics have a lower risk of abuse, withdrawal, and tolerance compared with older non-selective benzodiazepines such as triazolam and temazepam. These attributes make non-benzodiazepine hypnotics more desirable for the treatment of chronic insomnia. Both zolpidem controlled release and essoplon are FDA approved for chronic insomnia and are effective for up to 3 to 6 months of therapy. Zolpidem has been studied up to 12 months and was not associated with rebound insomnia or withdrawal symptoms. Additionally, essoplon was studied for 12 months of nightly administration and found to be well tolerated with no tolerance observed. Another potential advantage of non-benzodiazepine hypnotics' alpha-1 subunit selectivity is little to no change in sleep architecture or sleep stages. Temazepam and flurazepam increase the percentage of stage 2 sleep, but can suppress REM and stage 3 and 4 deep restorative sleep. In contrast, non-benzodiazepine hypnotics do not interfere with these sleep stages and have lower rates of uncomfortable REM rebound, vivid dreams, increased autonomic instability, on discontinuation. The non-benzodiazepine hypnotics differ with respect to pharmacokinetics and adverse events. Zolpidem, the first non-benzodiazepine hypnotic, was marketed in the United States in 1991. It is absorbed rapidly, reaches peak serum levels in 1.5 hours, and is eliminated rapidly with an average half-life of approximately 2.5 hours. For faster sleep onset, zolpidem should be taken on an empty stomach for faster absorption. A food effect study demonstrated that administration of a zolpidem 10 mg tablet 20 minutes after a meal resulted in a decrease in AUC and C marks of 15% and 25%, respectively, and an increase in the Tmax from 1.4 to 2.2 hours. Zolpidem is metabolized by the oxidative cytochrome P450 isoenzyme CYP3A4. Therefore, drug interactions should be considered when zolpidem is co-administered with CYP3A4 inhibitors such as diltiazem or fluoxetine. Zolpidem has no active metabolites, and it has a low risk of residual daytime sedation in recommended doses. Zolpidem controlled release has no clear advantage over zolpidem, except that it may provide a slightly longer duration of sleep. Zolpidem controlled release is a bi-layered tablet that has a first layer that dissolves quickly to induce sleep and a second layer that releases zolpidem more gradually to improve sleep maintenance. Serum concentrations peak in 2 hours compared with 1.5 hours for immediate release zolpidem, with an associated longer latency to effect. Of note, zolpidem has been approved as oral spray to help with sleep onset. Due to buccal absorption, it has a rapid onset of action of 10 minutes. In 2013, the FDA approved a new label change and dosing for zolpidem products to recommend avoiding driving the day after using zolpidem controlled release. Also, gender metabolism differences exist where women metabolize zolpidem slower than men, resulting in blood levels nearly twofold higher. As a result, in women or the elderly, the recommended starting dose is 5 mg zolpidem immediate release or 6.25 mg zolpidem extended release. For PCB, though the usual adult dose in males for zolpidem immediate release is 10 mg at bedtime, women, elderly, or patients such as PCB, who express concern that a medicine may be too strong, should begin with 5 mg at bedtime. Zaleplon offers a shorter elimination half-life, approximately 1 hour, and duration of effect than zolpidem. It is least likely of all hypnotic agents to cause residual daytime sedation and has the least effect on memory and psychomotor performance. An assessment of psychomotor performance, arousal, memory, and cognitive functioning with Zaleplon revealed no cognitive impairment. The most common adverse effects with Zaleplon include dizziness, headache, and somnolence. In dose escalation studies using up to 60 mg, symptoms appear at approximately 30 minutes after dosing, peak at 1 to 2 hours, and are no longer evident after 4 hours. It can be taken in the middle of the night as long as the individual has 4 hours left in bed. Zaleplon is metabolized primarily via aldehyde oxidase. CYP3A4 is a secondary route of metabolism, and there are no active metabolites. It has less potential for drug or food interactions compared with zolpidem or S-soprolone. S-soprolone maintains efficacy with no evidence of tolerance after 6 months of continuous use, resulting in FDA approval for long-term use. Hypnotic efficacy has been demonstrated for up to 6 months in younger patients taking 2 to 3 mg nightly, and in elderly patients taking 1 to 2 mg nightly, although only the higher range of doses significantly improved sleep maintenance. As with zolpidem and Zaleplon, S-soprolone has a rapid onset of effect, but differs in that it has a longer duration of effect. Time to maximal concentration, abbreviated as Tmax, is delayed up to 1 hour when S-soprolone is administered after a high-fat meal, potentially delaying the onset of sleep. S-soprolone has less receptor selectivity than either Zaleplon or zolpidem, potentially resulting in some anxiolytic, amnestic, and anticonvulsant activity. Among the 3 Z hypnotic drugs, S-soprolone has a dose-related unpleasant bitter taste noted by 16% to 34% of patients. Headache and dizziness were reported more commonly with S-soperclone than placebo, and at higher doses, next-day confusion and memory impairment were reported in up to 3% of patients. S-soperclone is primarily metabolized by CYP3A4, so drugs that induce or inhibit this isoenzyme can have an impact on metabolism and a clinical effect. PCB needs a medication that will hasten sleep onset, but does not need continued drug effect later in the night. Both zolpidem and zaleplon are useful alternatives for PCB because of their efficacy for his sleep onset difficulty. However, zaleplon may be preferred due to quick onset and short half-life to mitigate the risk of next-day hangover. Among the NBRAs, S-soperclone has the longest half-life and the greatest risk for next-day impairment. Zolpidem 5 mg is prescribed because of its rapid onset, low cost, and lower risk for next-day impairment. PCB expresses concern about possible adverse effects owing to its labeling as a Schedule IV controlled substance and the FDA warning of complex sleep behaviors such as night eating and night driving. So my question to you reads: how should PCB's concerns be addressed? Patient counseling is most effective when it is interactive with both patient and practitioner actively listening to each other while exchanging information. It is best to begin by emphasizing the benefits of zaleplon to improve his sleep and daytime functioning. Next, PCB should be reassured that zaleplon is generally well tolerated and he will be prescribed the lowest dose to minimize the likelihood of adverse effects. Counseling should include a discussion of common and potentially serious adverse effects along with management strategies. Common possible adverse effects include headache, that is 30%, abdominal pain, that is 6%, asthenia, that is 5%, somnolence, that is 5%, and dizziness, that is 7%. Anaphylactoid reactions and nightmares have been reported in post-marketing studies. Additionally, PCB should be encouraged to report both effectiveness and all adverse effects to his clinician. Alcohol should not be consumed together with zaleplon or any non-benzodiazepine hypnotic because it can cause excessive side effects and interfere with PCB's sleep. To address PCB's concern regarding complex sleep behaviors, a reasonable response would be, rarely, individuals taking sleeping medication have been reported to be making phone calls, eating, having sex, or driving while half asleep. The risk for these potentially dangerous effects increases if consumers take a higher than the recommended dose, or drink alcohol or mix hypnotics with other sedating medications. Another rare allergic reaction is facial swelling, that is angioedema. All manufacturers of hypnotic medication are required to include this information in their package inserts. Although the abuse potential of non-benzodiazepine hypnotics is less than benzodiazepines, they are problematic in active substance abuse disorders. Non-benzodiazepine hypnotics are Schedule IV controlled substances with more potential for abuse than Rameltian or sedating antidepressants, like trazodone. Tolerance and withdrawal associated with non-benzodiazepine hypnotics is unlikely but reported with abrupt discontinuation, and patients should be counseled of this possibility, particularly at high doses. PCB asks about a new sleep medication, suvorexant, and whether he could use this to help him sleep. What information can you provide PCB regarding the safety and efficacy of suvorexant for insomnia? Suvorexant is an orexin receptor antagonist FDA approved in 2014 for treatment of insomnia characterized by difficulty falling asleep and/or maintaining sleep. The orexin signaling pathway promotes wakefulness and arousal. Antagonism of orexin receptors can promote sleep. Studies show that suvorexant can decrease latency to onset of sleep and wake after sleep onset without disrupting the sleep architecture. The initial recommended daily dose is 10 mg within 30 minutes of bedtime and with at least 7 hours of sleep time available. Suvorexant should be taken on an empty stomach as time to sleep onset may be delayed by 1.5 hours if taken with or soon after a meal. If needed, the dose can be increased in 5 mg increments to the maximum recommended daily dose of 20 mg at bedtime. Suvorexant is a CYP3A substrate and a dose reduction of 5 mg daily is recommended when administered concurrently with a moderate CYP3A inhibitor. Concurrent administration with a strong CYP3A inhibitor is not recommended. No rebound insomnia or withdrawal symptoms have been observed following abrupt discontinuation. 64 When compared to zolpidem, suvorexant is associated with less abuse potential and, like benzodiazepine receptor agonist hypnotics, is a Schedule IV medication. The most commonly reported adverse effect in clinical trials evaluating suvorexant was daytime somnolence. Complex sleep behaviors, a dose-dependent increase in suicidal ideation, sleep paralysis, hallucinations, and cataplexy-like symptoms have been reported with suvorexant. Suvorexant is contraindicated in patients with narcolepsy. Studies comparing suvorexant to other hypnotic agents, such as the Z hypnotics, are lacking. The role of suvorexant in the treatment of sleep disorders has yet to be established. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arora, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 565.